In today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Rajnish Mago about the most current research on interactions between food, beverages, and psychiatric medications. For complete CME information, please refer to this podcast description page or go to nei.global/podcast. Let's listen in as Drs. Cutler and Mago discuss food and beverage interactions with psychiatric medications.
So, Raj, I have to tell you, I've really been looking forward to this discussion because of how practical this is for anyone who prescribes medications. And typically, we are taught pharmacokinetics, and when we're taught the concepts of ADME, ADME, which is absorption, distribution, metabolism, and elimination. Right. I think that this topic really lends itself to talking about absorption and metabolism. Can you speak a little about how food can affect particularly absorption and metabolism of our medications?
Sure. Thank you, Andy, again for having me on this podcast. The thing is, there are many medications, psychotropic medications, that are not particularly affected by food except for tolerability, right? We get into this habit of telling people to take their medications with food because nausea is the commonest side effect for many of our medications. So that we all know, and that is generally a good practice. But that's not what we are going to talk about in this podcast. For maybe 5 or 10 medications, food has an important effect on their pharmacokinetics in a completely different way. The amount of food that you take with the medication can have a huge effect on the absorption of some medications, like the extent to which they are absorbed. So that's number one. Number two is taking the medication with food or without food can completely change how the curve of the medication is. That is the concentration. As you take the medication, the concentration in the blood rises and then falls, right? That's the curve. Mm-hmm. If with certain medications, when you take it with food, it'll, so to speak, flatten the curve. We've been talking a lot about flatten the curve with the coronavirus.
Yeah, it's very timely.
Some of the medications, if you take them with food, it'll flatten the curve. That is to say, it won't have such a sharp peak, and the peak will occur later. And with another medication, it'll be the opposite, where if you take it with food and some which is without food, it'll flatten the curve. So that's a second type of effect, which is not just the amount, but the profile of the absorption. Mm-hmm. A third thing foods and beverages can do is that they can affect the cytochrome P450 system by inducing or inhibiting some of the enzymes. So certain medications, especially clozapine, for example, but also others, can be affected because of the cytochrome P450 system. So it goes to show that there are many different ways in which food and beverages can have an effect. I don't want clinicians to become obsessed with trivial and unimportant things. So what we are going to talk about is only when it makes a big difference.
I see. Well, that's really important and very helpful. A lot of times we see that it specifies that we have to take a certain medication with food. How do we know how much food and the content of the food as far as maybe fat composition? How can we find this out?
So with a lot of medications, we tell people to take the medication with food, and usually that is due to tolerability, like I already said. Yes. But what we are talking about here is there are 3 psychiatric medications in which if you do not take them with food, half of it is not going to get absorbed. So these are lurazidone, vilazodone, and ziprasidone. Can you imagine if a patient came to you and you had prescribed 80 milligrams of lurazidone, and the patient said, oh, sorry, I'm only taking half. I'm only taking 40 milligram. Wouldn't you think that's a big deal? 80 milligram versus 40 milligrams is a huge difference. That is the exact amount of effect. That's the degree to which there is going to be a loss of efficacy of lurazidone if you do not take it with food. Yet every day I see patients who have been treated by different psychiatrists, and they are surprised when I tell them that you must take this medication with food, otherwise it's not going to get absorbed. Many times they will take the medication at bedtime. And at bedtime they are not eating. So they're taking it with either no food or negligible amount of food. So that's why I'm really harping on this point that this is really a big deal.
The vilazodone is one that we don't think of so much with food.
Right. There are a couple of other medications in which also the absorption is increased with food, like buspirone, and paliperidone, but in those the effect is not so pronounced, and so the recommendation is only for buspirone and paliperidone. The recommendation is simply to take it consistently. Either you always take it without food or you always take it with food. But for lurazidone, vilazodone, and ziprasidone, you must always take it with food. Now, coming to your question of how much food. So typically they will do studies, the FDA mandates these studies. These studies are done for all medications that are introduced and different levels of food. So they'll have people in a fasting state, maybe something like 300 calories, 500 calories, 1,000 calories, etc. Different degrees. These are not exact numbers, but like different amounts of food. And then also do a high fat meal and a low fat meal. The FDA, you would be surprised to know, it's actually amusing that the FDA specifies exactly what the person must eat, like 2 eggs and bacon. It's like a cardiac breakfast. It gives them a heart attack, I think. The high fat one. But anyway, so when they do these, so you can get a rough idea. So if you see that the absorption is decreased, if you go below a certain number of calories, they can make a general statement. So for lurazidone, for example, the recommendation is that you need to take at least 350 calories. For ziprasidone, the recommendation is that about 500 calories. So because this is confusing, I'm going to make a very general statement which makes it simple. Approximately 500 calories is how many calories you should take. So you're not talking about one cookie, like a cookie. Right. I'm on a diet nowadays, Andy, so I'm obsessed with calories. I can tell you the caloric value of everything because that's all I think about all day is food. And so one homemade cookie is 140 calories. A homemade chocolate chip cookie, which I love, is 140 calories. You have to have an actual meal. So like if you have a substantial sandwich, that's about 500 calories, like a full sandwich, a turkey sandwich, or, something like that, a ham and cheese sandwich, that would be about 500 calories. So this is important to emphasize because sometimes a patient might take like some very small snack. That's not enough. That's not enough food.
And what about the fat content? I understand for lorazepam, it doesn't matter.
It doesn't matter. So usually the fat content doesn't seem to matter. And this is something that we know the answer to. We are not guessing because like I said, they are FDA mandated studies where they do the high fat and low fat meals. So we do know, we have actual data on this. And the fat content in general doesn't seem to matter for these medications in terms of how much is absorbed. It's a general statement that if you eat a high-fat meal, that's going to delay the absorption because fat takes longer to leave the stomach. So it's going to delay the absorption. This is similar to, Andy, if you have alcohol, right? If you have alcohol with food, you're not going to get such a spike. It's going to slow down the absorption. You're not going to get drunk as easily, and it'll sort of mellow out the effects because it'll get absorbed over time. And if you have a high-fat meal, this effect might be more pronounced. So here's the thing. So in general, fat content doesn't matter except that it might slow down the process, but it doesn't affect the amount of absorption. But there are only one or two exceptions to this. One of them is the extended release form of quetiapine. The extended release form of quetiapine is a very rare case of a psychiatric medication which is better taken on an empty stomach, either on an empty stomach or with very small amount of meal. Because what happens is here, there's a flattening of the curve. You can take 600 milligrams of quetiapine extended release all at the same time and yet not get a very high peak level because if you take it on an empty stomach. And so in some cases, that's desirable, right? You don't want the peak level because peak level correlates with side effects. If you take it with food and especially with high fat. So here's an example of where the fat does make a difference. If you take it with high fat, now you're going to get a sharper spike in the peak level. And it'll come earlier and you can have more side effects from the quetiapine extended release.
You're turning it into almost like immediate release.
Exactly. And this is a problem because quetiapine extended release often is prescribed at night, and you do want to get a peak to some extent because a peak can help people to sleep. So one has to be thoughtful about what are you trying to achieve. So let's say we want to prescribe zolpidem for sleep, which we do commonly. I prescribe it like almost every day. Now with zolpidem, do we want to get a peak or we don't want to get a peak? I think that we do want to get a quick absorption, and we want it to reach a peak so that the person quickly transitions into sleep. And so it is a general rule of thumb that sleep medications should be taken without much food. Because if you take them with food, then two things will happen. The peak level will not be as high, and the peak level will occur later. So it may take 1.5 to 2 hours to reach peak level. That's a long time to be waiting to fall asleep. So isn't it interesting? Like once we understand the principle of the thing, then we can think to ourselves, do we want the peak level or not? Do we want the effect to occur quickly, or do we want the curve to be flattened out?
So it occurs to me that the high-fat meals, by delaying the absorption, this is what you were talking about with flattening the curve or changing the shape of the pharmacokinetic curve, but not necessarily changing the total amount absorbed overall.
That is correct.
I think that's important for people to realize. So the same amount might be absorbed, but it's very different with or without food as far as these peaks and when they occur.
Right. The difference between a psychopharmacologist and a master psychopharmacologist is in the detail. And it's this kind of attention to detail that can make subtle differences in using the same medicine skillfully.
Well, I think everyone who's listening here, our audience all wants to be master's level. So I think with your education, they're going to be well on their way. Now, I do have a question here about extended release medication. How does that differ? Now, I think you've talked about that specifically with quetiapine XR, but in general, it sounds like you're delaying the absorption even with extended release medications. Is that correct?
That's right. Because, how the extended release preparations typically, they are different mechanisms, but the most common mechanism is that they have a coating that dissolves when they reach an alkaline environment. So when the medication leaves, there's either delayed release preparation or extended release preparation, which is not the same thing, but they are similar. Like divalproex delayed release or venlafaxine extended release. So typically what is happening is they have a coating, and when the medication leaves the stomach and goes into the intestine where the environment is more alkaline, that's where the medication starts to release. So anything that's going to change the rate of gastric emptying is going to change the timing of effect of the extended release medication.
I see. Well, I have a different question for you here. I know that there are some medications, we talked about fat content, but there are some medications affected by acidification or the acid-base environment. And specifically, vitamin C, I know, is an acidifying agent, and I understand that can affect certain medications.
Yeah, we should remember that vitamin C, the other name, the chemical name for vitamin C is ascorbic acid. It's an acid. So here's the thing, I take a multivitamin pill daily. It has I think 40 milligrams of vitamin C, which is like a recommended daily allowance is 40 to 60, something like that. That's probably not going to make a big difference. But there are many people who take large amounts of vitamin C, 500 3 times a day or 1,000 milligrams twice daily, because they believe, I don't know for sure whether it's true or not, but they believe that it increases their resistance to colds, that it improves their immunity, and so on.
Linus Pauling certainly thought so.
Right. Yeah, that's right. So when you're taking such large doses of vitamin C, and this is rampant, if you go on Amazon or something, you'll see so many advertisements and so many products available with large doses of vitamin C. So this is a very common practice. This is not a rare thing. When you're taking that level of vitamin C, then your urine is going to be acidic. And amphetamine is like a weak alkali, a weak base. And so when the urine is acidic, the amphetamine gets excreted in more easily. In fact, if a person overdoses on an amphetamine, that's one of the treatments, is to give them something that will acidify the urine.
What percentage does it affect?
It'll pretty much double the rate of excretion. The difference will be very substantial. Again, we are talking about if the person takes these kind of doses, 500 3 times a day or so. So maybe a 50% increase the amount of amphetamine that's being excreted. So it is a clinically significant. As I said when we started, everything that we are talking about in this podcast is talking about things where there is a substantial difference which is clinically relevant.
So this is at least half, maybe even more of an effect. That is quite impressive. Now, A lot of people like to drink drinks that have caffeine. I know I had my coffee this morning. Caffeine is used quite commonly. I understand caffeine can affect metabolism of medications.
Yeah, just wait a second. Let me take a sip of my coffee, then I'll answer you. Yeah, caffeine, yes. The most widely used psychoactive substance in the world, right? Yeah. Mm-hmm. So so in terms of, caffeine is a concern for our patients in many different ways. For example, can make a person anxious when used in large quantities. During withdrawal, it can give us headaches. It can contribute to insomnia much more often than people think, because people don't realize that the half-life of caffeine on an average about 5 hours, which means that you have to stop taking caffeine not like after 5 p.m., but like after 10 a.m. But in terms of the pharmacokinetics, the reason the caffeine is relevant is because it inhibits the enzyme cytochrome P450-1A2. Mm-hmm. It inhibits the enzyme. Smoking induces the enzyme and caffeine inhibits the enzyme. Mm-hmm. Several psychiatric medications that are metabolized in part by 1A2, but the only one in which this is a big deal is clozapine. Mm-hmm. Because clozapine is metabolized primarily by 1A2, that's one reason. And then the second is, as we know, clozapine has a somewhat narrow therapeutic window. Mm-hmm. It doesn't have as much of a safety margin as other medications. If a person who is on clozapine is in the hospital, is not consuming much caffeine, then this person goes home and they go back to their habit of having several cups of coffee every day. Their clozapine level can easily double when there is significant caffeine, and then the person can develop toxicity.
Wow. So I understand olanzapine and asenapine are also metabolized by CYP1A2, but are you saying that it's not predominantly like it is with clozapine? Is that correct?
With olanzapine, the data is contradictory at this time. We do not think that caffeine will clearly affect olanzapine levels, and I think that's because olanzapine is also metabolized by the UGT system, so it has alternative pathways of metabolism. So clozapine is the main one that we should remember. For different medications, the 1A2 induction by smoking or inhibition by caffeine is mentioned. For example, fluvoxamine, there's about a 25% difference. For duloxetine, there's a 20% difference. So the differences are small. And so we don't have to keep tracking how much caffeine the person is taking because the difference is not so big. But with clozapine, we need to track any significant change in their caffeine intake or their level of smoking. We need to be very aware.
For caffeine, is there a certain amount of milligrams that induce this effect? Or
that's a great question. It's not been systematically studied, so we don't have great data. We have indirect evidence. Firstly, let me say it is clearly dose related, so that the more caffeine you take, the more inhibition of 1A2 there is going to be. And we have indirect evidence from looking at different case reports of people who developed clozapine toxicity or had elevated levels after they started to increase their intake of caffeine. So we know that it's clinically significant by 400 milligrams of caffeine per day. So just to give you an idea, a 12-ounce cup of Starbucks coffee, what they call in Starbucks language, they call tall, it contains 260 milligrams of caffeine. So if a person is having even 2 cups of that kind of coffee, strong coffee, more than enough to produce potent inhibition of 1A2.
Now, a lot of our patients like to smoke a cigarette with their coffee. And you just mentioned that cigarettes seem to have the opposite effect. They induce 1A2. Is that correct?
That is correct. And see, that's very interesting that they have the opposite effect. There's a fascinating observation that people who smoke, they drink a lot more coffee. And the reason for that is that caffeine is also metabolized by 1A2, the same enzyme that it inhibits. And so people who smoke need to drink a lot more coffee to get the same effect.
That is fascinating.
A lot more coffee, yeah.
Now, the same question I asked about milligrams of caffeine. Is there a certain number of cigarettes or certain packs of cigarettes a day that's going to cause this effect? Is there a threshold?
Yeah, again, we don't know this for sure. So this is an estimate based on a paper by Jose de Leon. So this is, to be taken with a grain of salt, but approximately 10 cigarettes, which is half a pack, is sufficient to produce clinically significant induction. And then after one pack, you pretty much max out. So there is a max, like after about a pack of cigarettes, it's not going to be induced any further. So somewhere between 10 to 20 cigarettes is the range during which the induction of 1A2 occurs.
Well, most of our patients are smoking at least that much, if not quite a bit more.
Unfortunately. And especially patients with schizophrenia who are not doing well. They are the ones who are on clozapine, right? Those are exactly the kind of patients who are going to be smoking a lot. Linking the two questions that you asked, how much caffeine makes a difference also depends on whether the person is a smoker or not a smoker. So if the person is a non-smoker, and their caffeine intake changes by drinking one more cup than they did before, it could make a clinically significant difference. If they are a smoker, they would have to increase their intake by about 3 cups before it'll be clinically significant, because as I mentioned before, smoking induces the metabolism of caffeine also.
Now, caffeine also is a diuretic, I understand, and so there's potentially a relationship between caffeine and lithium. Yes,
that is true. Because as caffeine acts as a diuretic and water goes through the kidneys, it takes lithium with it. So drinking caffeine can lower the lithium levels. One very interesting practical application of this knowledge is that one of the commonest side effects of lithium is tremor, right? Benign tremor. It is very bothersome to patients because it's socially embarrassing. So they frequently come and complain a lot about the tremor, even if it's not a toxicity, but like they really hate the tremor. A simple advice that I give is like the very first thing to do is to ask them to reduce their caffeine intake, because caffeine increases lithium tremor. They have a synergistic effect. Now, when you ask them to reduce their caffeine intake, because we said that caffeine leads to greater lithium excretion, when they're taking less caffeine, their lithium levels will increase. So I was treating a person who was drinking 10 to 12 cups of coffee, complained a lot about lithium tremors. I asked him to reduce his caffeine intake to no more than 2 cups. The lithium level went up quite significantly. So if there's a significant decrease in caffeine, there's going to be an increase in lithium level. And if you don't alter the dose of lithium accordingly, the tremor may actually get worse. They could become toxic, or they may say that as I decrease the caffeine, actually I'm having more tremors, not less. You said that my tremors would get better, but tremors are getting worse. There's a classic paper by James Jefferson, and the title of that paper is something like Drinking Less and Shaking More. That's a way, it can be a way to remember, because our listeners might get confused later on. Wait a minute, what did they say? So just remember, drinking less and shaking more. If they drink less coffee, the lithium level is going to go up.
Well, you just made me smile, because Jeff Jefferson was a mentor of mine and really a giant in the field of psychopharmacology, especially with respect to lithium.
Yes, definitely.
Let's shift gears a little here. You know, I live in Florida, Raj, and here the citrus industry is really big. So I understand that I always have to talk with my patients about grapefruit and grapefruit juice. And how does that affect the system?
Yeah, so I personally don't eat grapefruit usually, unless I'm staying at a hotel and like eating a buffet breakfast or something. I have seen so many patients, if you ask them, especially older patients, they tend to like grapefruit. And I guess maybe it's more in Florida. So even if the clinician who's listening to this podcast, even if you yourself don't eat grapefruit, you should realize that at least 20% of households consume significant amounts of grapefruit. So we should know about the effects.
My father had half a grapefruit every morning.
Is that right? Okay. Yeah. I mean, it has vitamin A, it has vitamin C, it has relatively fewer calories. So these are the reasons why people think that grapefruit is a good thing. In terms of coming back to what is the relevance to psychopharmacology, is that grapefruit inhibits the cytochrome P453A4 enzyme that's present in the intestine. And even like just eating one grapefruit or just one cup of juice is sufficient to potently inhibit 3A4 for the next several days.
Well, this is very important. 3A4 is a very common enzyme that metabolizes drugs. Is that right?
That's right. So there are certain medications. So it affects psychotropic medications to different extent depending on the medication, starting with buspirone, whose levels go up like 900% increase in the level if you eat one grapefruit or 1 cup of grapefruit juice, or diazepam, which we don't prescribe that much now, but like the levels will go up 3 times. But carbamazepine is another one where levels increase. Some of the second-generation antipsychotics like lurazidone, quetiapine, SSRIs like fluoxetine, PDE5 inhibitors like Viagra and Cialis, they are also metabolized by 3A4, and there is a warning that the person should either avoid grapefruit juice or you would have to significantly alter the dose. So it's best to tell them to avoid grapefruit juice and just not get into this issue of 3A4 inhibition.
Yeah, I've seen this warning on a lot of our psychotropic medications, particularly, as you said, a lot of the atypical antipsychotics.
Yes. Yeah, it's better to avoid rather than remembering all the details of exactly which medication it affects and so on. It's probably a good idea to encourage these patients to not take grapefruit in the first place. That might be the best way to get away with it.
Yeah, CYP3A4 metabolizes, I think, if not half of the majority of medications in general.
Right, That's true. So a lot of non-psychiatric medications like, for example, cholesterol medicines, I take atorvastatin for high cholesterol. Cholesterol medications are very significantly affected by grapefruit juice, so it needs to be avoided. One thing people think wrongly, so patients, I have had this situation. See, it's amazing like how much detail there can sometimes be. So when I told patients that, hey, listen, grapefruit juice can interact with your medication, what they'll do is they'll say, in that case, I'll take the grapefruit in the juice in the morning and I'll take the medication at night.
Yes.
At night. So they think it's just an issue of whether you take it at the same time or not. But that's not how it works. It's an irreversible inhibition. So once the grapefruit juice causes inhibition of 1A2, it's going to take about 3 days before new 1A2 is regenerated. So you cannot get around this problem by just separating the time and taking grapefruit and the medication at a different time. That will not solve this problem.
It's the effect that happens with the first ingestion of grapefruit, then, if it's irreversibly inhibiting.
For approximately 3 days. Yeah.
The last 3 days. Boy, see, Raj, I just learned something. I didn't know that. That's very important. Let's talk just about, we've talked about grapefruit. Are there some other foods that we need to know about that are inhibitors or inducers of cytochrome P450 system?
No, we talked about the ones that are particularly important. And the reason for that is because the extent of effect is great. There are different foods that can induce or inhibit cytochrome P450 enzymes. Like, for example, cruciferous vegetables like cabbage, cauliflower, broccoli. These are induced 1A2. The reason I don't think we need to worry too much about them is because most people are not consuming extraordinary amounts of these vegetables. Like, if a person was like eating broccoli with every meal or like in large quantities, it would be an issue. So we generally don't need to worry about this. So let me mention one more beverage that has a clinically significant effect, and that is chamomile tea.
Oh.
Yeah, I want to make a general comment that I have been really surprised by the extent to which Americans use herbs and supplements. And I would encourage all our listeners to make it absolute practice that when you ask people what medications are you on, ask them specifically any supplements and any herbal products and so on. So chamomile, either in the form of tea or in the form of supplements, is commonly used. And I think there is some actually good basis for chamomile helping with sleep. But chamomile also, like grapefruit, inhibits 3A4 and will increase the effects of these medicines like buspirone, benzodiazepines, hypnotics like Ambien, like zolpidem and so on. Chamomile, either in the form of tea or a supplement, is another product that has a clinically significant interaction with cytochrome P450.
To your point about how often Americans like supplements, I've always joked that we seem to like our chemicals with stems and leaves attached to them, something natural. But this is an important point. We need to know everything that our patients are taking because there are some of these supplements can have significant effects.
Absolutely. It drives me nuts to hear people say that it's a natural product and therefore it's harmless. There is zero truth in this. Natural products contain potent chemicals also. And just like they can have certain benefits, they can have certain adverse consequences. And they need to be studied just as seriously as conventional medications. You agree, right?
Oh, absolutely. 100%. It's a little beyond the scope of what we're talking about today, but when I think of stems and leaves, of course, I think about marijuana. And marijuana, I understand, cannabis can inhibit cytochrome P450-3A4.
Yes, that is true. Now, with cannabis, the one very important distinction, though, is that it depends on whether it's being smoked or whether it's being taken in the form of a pill. Nowadays, people have started taking cannabis in the form in various edibles. Hey, I don't know from personal experience, but I've heard that people do this. So in the case of cannabis, THC, tetrahydrocannabinol, cannabis contains almost 100 chemicals, and THC is the chemical that makes people intoxicated, and there's cannabidiol, which also a lot of people are taking over the counter. They have different effects on the cytochrome P450 system. THC inhibits 2C9 and 3A4. Cannabidiol inhibits 2C19 and 3A4. 2C9 and 2C19. One doesn't have to remember. I think that it can be overwhelming for the clinician to remember the exact enzymes. But the important thing is to remember that certain cytochrome P450 enzymes can be affected by cannabis. And if a person is taking cannabis, then we need to look up what is the interaction between cannabis and the medication the person is taking. If they are smoking the cannabis, smoking cannabis produces the same aromatic hydrocarbons that cause induction of 1A2, the same as smoking tobacco. So smoking tobacco and smoking cannabis has the same effect on 1A2.
Well, again, very important to know. Raj, this has been an absolutely fascinating discussion, and I can tell you, I certainly understand why your lectures for NEI are rated so highly. This is incredibly practical and important advice, and, it makes me think, where else can people go to learn more about drug interactions with food and beverages? And please feel free to talk about your website.
Thank you, Andy. So, there are various sources that people can look this up. The most important table that I recommend on the internet is people can Google it, is the Flockhart table, FLOCKHART, Flockhart table, which is maintained by the University of Indiana, which lists different medications under like different cytochrome P450, which one is a substrate, inducers, inhibitors of each of the enzymes. Mm-hmm. But, I've been doing this for a very long time, and I found that for clinicians, information about different aspects of psychopharmacology is a very complex field. And, people who are busy seeing patients, it's so hard for them to get all the knowledge in a simple way, in a brief, simple, practical way. And that's why I started this website several years ago. It's called simpleandpractical.com. Simpleandpractical.com. Thousands of subscribers all over the world, they read this, and I try to give people only practical information in the briefest possible way and written in simple language. And the feedback has been just fantastic. A lot of people are benefiting. So if the listeners are interested, they should check it out, simpleandpractical.com.
Well, I can certainly recommend this website, and I can also recommend, if you get the opportunity, please come hear Dr. Mago live. He's wonderful and entertaining, as you can hear, and very practical and engaging. So, Raj, I want to thank you once again for a really informative podcast.
Thank you so much, Andy, for having me.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to go online and print your certificate. This concludes the CME podcast presentation.